Hello, my name is Vanessa Paquette, and I'll be presenting a case on a 72-year-old female who presented with shortness of breath. This case highlights diagnostic reasoning, cultural and ethical considerations, and the role of collaborative patient-centered care in managing early heart failure with preserved ejection fraction. For the subjective portion, the patient is a 72-year-old female who presented to the primary care clinic with a complaint of increasing shortness of breath on exertion over the past 2 months. She described becoming winded when walking short distances, such as to her mailbox or from the parking lot to the clinic. The shortness of breath improves with rest, and she denies any chest pain, palpitations, or dizziness. She also denies cough, wheezing, orthopnea, and proximal nocturnal dyspnea. She has noticed some mild fatigue, but reports being able to complete most of her daily activities at home. When I asked about her medical history, she shared that she has hypertension, diabetes, high cholesterol, all of which were diagnosed several years ago. She currently takes lisinopril, atorvastatin, and metformin daily. However, she did admit to being forgetful with her medication sometimes. She said, some days I'm not sure if I've already taken it or not, so I just don't take it that day. She lives alone in a small rural community and is retired from teaching. She does not smoke or drink alcohol. She reports eating mostly home-cooked meals, but does use canned and processed foods sometimes for convenience. She doesn't have a car and depends on a neighbor for transportation to appointments or to pick up prescriptions. When discussing her symptoms, she seemed a bit concerned and said, "I just don't want to end up in the hospital like my husband did." This statement provides insight into her motivation to stay healthy and independent. During the review of symptoms, she denied swelling, chest tightness, or weight gain, but did note that she gets tired more easily. She has not noticed any recent fever, cough, or signs of infection. Overall, her main concern is understanding what is causing her shortness of breath and making sure she can continue to live independently and safely at home. Moving on to the objective portion of the exam. When the patient arrived at the clinic, her vital signs showed a blood pressure of 152/88, which is above the goal for her age and medical history. Her heart rate was 92 beats per minute, respiratory rate 20, and oxygen saturation was 95% on room air. Her temperature was normal at 98.2 degrees Fahrenheit, and her BMI was 29, which places her in the overweight category. On general assessment, she appeared alert and oriented, but mildly winded after walking from the waiting area to the exam room. She was in no acute distress and communicated clearly throughout the visit, though she occasionally needed reminders when reviewing her medication list. On cardiac exam, her heart rhythm was regular with normal S1 and S2 heart sounds. There was a soft S4 gallop heard, which could suggest decreased ventricular compliance. This would be consistent with diastolic dysfunction. There were no murmurs, revs, or extra heart sounds appreciated. There was no jugular venous distension and no carotid bruits. On respiratory exam, lung sounds were clear in all fields without rales, wheezes, or rhonchi, which helps to rule out a pulmonary etiology for her dyspnea. Her chest expansion was symmetrical, and she denied tenderness or pain with deep inspiration. Peripheral assessment showed bilateral ankle edema rated at a 2+ pitting. Peripheral pulses were palpable and equal bilaterally, and capillary refill was under 2 seconds. Skin was warm, dry, and intact, and no cyanosis or clubbing was noted. For neurological status, she was alert and oriented person, place, and time, but demonstrated mild short-term recall while discussing her medication schedule. Gait was steady, and no focal deficits were noted. Her diagnostic results provided key information for clinical decision-making. EKG showed sinus rhythm with left ventricular hypertrophy and nonspecific ST wave changes, suggesting chronic hypertension and cardiac-related changes. BNP level was 195 picograms per milliliter. which is elevated and supports early heart failure. Complete blood count and basic metabolic panel were both within normal limits, ruling out anemia or electrolyte imbalances for the dyspnea. Chest x-ray revealed mild cardiomegaly, but no pulmonary infiltrates or congestion. These findings point toward a cardiac cause for her shortness of breath, likely related to heart failure with preserved ejection fraction rather than a respiratory or hematologic condition. These findings also guided the next steps in her care, including confirming the diagnosis, optimizing medications, and addressing safety and adherence concerns. Based on the patient's presentation and diagnostic findings, my primary diagnosis is heart failure with preserved ejection fraction. This diagnosis is supported by several key findings: the patient's exertional shortness of breath, fatigue, ankle edema, all which suggest mild fluid retention and reduced cardiac efficiency. Her elevated BNP level supports a cardiac etiology rather than a pulmonary or hematologic cause. This is also supported by her EKG showing left ventricular hypertrophy. And then we have the chest x-ray that also ruled out a pulmonary cause and further supports chronic hypertension with the mild cardiomegaly. In heart failure, the heart's pumping function is normal, but the ventricles become stiff and do not fill properly. So this results in the increased pressure and fluid buildup during exertion. Some secondary diagnoses include hypertension, which remains suboptimally controlled due to medication non-adherence, likely due to mild cognitive changes. She also has hyperlipidemia, which is currently stable on the atorvastatin. Blood sugars are stable as well with the metformin, so no changes would be made there for her. Differential diagnosis, some main ones considered were stable angina, physical deconditioning, and anemia. However, angina is less likely in the absence of chest pain, and the anemia was ruled out with the CBC results. Deconditioning may be a contributing factor, but it's not the primary cause of her symptoms. So in summary, the patient's symptoms and findings point toward early heart failure with preserved ejection fraction related to long-term hypertension and poor medication adherence, all of which are compounded by possible social isolation and limited access to specialty care. The plan includes adding a low-dose thiazide diuretic for blood pressure control and using furosemide as needed for swelling or sudden weight gain. Education focused on limiting sodium, daily weight checks, and recognizing red flag symptoms that warrant emergent care. She will follow up in 1 week for labs and in 4 weeks for BNP recheck to see how those are trending. And then referrals were made to cardiology for further workup and connecting her to community resources for transportation and further support. Several key cultural factors are influencing this patient's care, and they include communication, social support, and time orientation. Connecting her with local senior programs can improve adherence, and by focusing on some short-term benefits can help keep her motivated and to stay engaged in her healthcare management. I also asked the patient about her goals and concerns, and she shared that staying independent was the most important thing to her. Ethically, it is important to respect her autonomy while ensuring her safety. Beneficence guided a care plan that supports her independence while preventing harm. She lives alone, so justice and advocacy also apply, just making sure she has access to the appropriate resources and support. So balancing these principles helps protect her overall well-being. This patient faces several health disparities. Living in a rural area limits access to specialty care, and her age and mild memory changes increase her risk for misunderstanding her plan. Transportation and cost barriers can also affect her ability to attend appointments. So these need to be addressed and require clear communication, telehealth options, and community referrals. I worked closely with my preceptor on this case, the nurse, and the care coordinator. The team discussed the abnormal findings and plans and made adjustments together at that time. The nurse provided additional patient teaching, and the care coordinator helped with transportation arrangements. Consistent documentation keeps the team aligned and ensures continuity of care. In summary, this case shows how nurse practitioners integrate clinical reasoning, collaboration, and cultural sensitivity in managing heart failure. Thank you for listening.